Okay, I've been asked to discuss with you fixed duration treatment for first-line CLL, primary treatment with ibrutinib plus venetoclax in previously untreated patients regarding the GLOW study. So we'll just go an overview of current treatment guidelines and then review the results of the GLOW trial, and then just have a panel discussion regarding the results. In the last years, we have had a lot of exciting and encouraging results on different randomized trials. So now it's even difficult to decide first-line treatment. And the first big question is whether we want a fixed duration first-line approach. And for that, we still have, and we can discuss whether there's still a role for chemoimmunotherapy. And then we have these other treatments with venetoclax plus obinutuzumab for 12 months regarding the results of the CLL14. And we also now have the options of having venetoclax plus ibrutinib regarding the results of GLOW and CAPTIVATE. And always we have the other option is the long-term duration of first-line approaches with ibrutinib, acalabrutinib, or zanubrutinib. So we wanted to discuss the results of the GLOW trial. I think we all know the GLOW trial were patients with previously untreated CLL. All patients or patients with comorbidities were randomized 1-to-1 to receive either chlorambucil plus obinutuzumab, which we all know is not the best control arm, or to receive a lead-in phase of 3 cycles with ibrutinib, and then to add venetoclax for a limited time of treatment. 200 well balanced between both arms with a median age of 71 years in both arms. Most patients had a CIR, a series of with a median of 9 or 8. Most patients, or 55% of the patients, were in stage 3 or 4, and only a few patients, that is expected in first line, had either deletion of 11q or TP53 mutations. And with the recently published results, we see that response by IRC was with a higher CR response rate in ibrutinib plus venetoclax, 38% versus 11% in chlorambucil plus obinutuzumab. I think we were all expecting these results with a significant better response in the experimental arm with ibrutinib plus venetoclax. And also was expected higher undetectable MRD rates with the new combination, which is in bone marrow around 52%, in peripheral blood around 54% with ibrutinib plus venetoclax, and 17 and 39% with chlorambucil plus obinutuzumab. And probably this is the most important results, and this is if we're going to incorporate this in our clinical practice. The estimated 3.5-year progression-free survival was 75% for ibrutinib plus venetoclax and 25% for chlorambucil plus obinutuzumab. We learned something also here, that there was a low impact on the PFS regarding MRD status for ibrutinib plus venetoclax, and that at 2 years post-treatment, most patients remained without progression regardless of MRD status. So new combination with fixed time treatment was consistent across all subgroups. Again, we have a very not such a powerful comparative arm with chlorambucil. And if we look at grade 3 or 4 adverse events, I think that there were no surprises regarding the appearance of new adverse events with the combinations. And we have patients with neutropenia, 37%, and even higher with chlorambucil plus obinutuzumab. But I think the most important thing is that we don't have any new emergent adverse events. We still see about 8% of hypertension, 6% of atrial fibrillation, thrombocytopenia, and 2.3 or 3% of cardiac failure. So as a summary, progression-free survival was significantly longer with ibrutinib plus venetoclax compared with chlorambucil plus obinutuzumab. And this was consistent across all subgroups. Adverse events were not remarkable and similar in both arms. So now we have a new option of doing some fixed duration with this combination regarding the results of both the GLOW and the CAPTIVATE trial. So what we need to discuss, and well, there are, I think, more things coming up, a lot more combinations, also some trials with ibrutinib plus venetoclax, and also new combinations, including ibrutinib, venetoclax plus obinutuzumab, and comparison of this versus chemotherapy. And with these new drugs, with acalabrutinib and zanubrutinib also being approved and recommended in first line, some new developments are still ongoing, combining venetoclax plus obinutuzumab and ibrutinib, or the triple combination with acalabrutinib, or venetoclax plus acala, or venetoclax plus zanubrutinib. So I think the point is to discuss how this can change our clinical practice, whether you think we are ready to incorporate this combination, fixed duration combination. Also, what is the impact of IgVH mutational status when using this combination? How does it compare to existing treatments, or is it going to be the winning combination? What is the impact of undetectable MRD if we do use this combination? And so I will open the discussion to see how does this compare to the existing treatments, and how you're going to incorporate these results in your clinical practice. So I think maybe Francesca, as an expert in the area, can start the discussion.
Yeah, thank you, Astrid, for your presentation. I think GLOW is reinforcing the concept of time-limited therapy for unfit patients. I think it's an important concept because we are seeing many resistance with continuous therapy, and also toxicities at the long run. So I think it's, as I said, it's reinforcing this concept. There are this is raising many questions. The first one is the toxicity that was observed in this unfit population. That was the reason that this therapy was not well implemented in many countries. For instance, the FDA didn't approve this combination for the United States. So I think it's one of the main questions that we have now for that. There are others that you already alluded, particularly the activity of this combination in patients with high-risk cytogenetics or high-risk molecular profile. We don't have a clear answer yet for that question. So in our clinical practice, we are prescribing more and more I plus V combination because people want to be away from the hospital, the tolerance is very good. So particularly for young people that want time-limited therapy, I think is the preferred choice now, at least I would say in Europe.
Can I comment a bit? Yes, me. Okay. So in addition to what Francesca said, I think it has to be emphasized that there are not many chances for a CLL patient to have time-limited treatment. And if probably only in the beginning, maybe in the second line, if possible. So I think it's really important to have it from the hospital perspective. Of course, we are a center of the German study group, so we usually tend to OB venetoclax, CLL14. However, our resources are going down and down in terms of admitting patients who have high TLS risk, etc. So it eases a bit of the load on the outpatient clinics and on the clinics makes it much easier for us. So I think it's a really valuable option. And my third point is that it may not even be the PFS that's so important, but it's also the time to the next treatment from the patient perspective. I mean, how long am I free of treatment? And I think with that combination, you get that just as well as with venetoclax. So it's a good alternative. With the caveat of the side effects, yes. So maybe we tend to select the younger old people, that's younger and fitter people for that treatment.
We're approaching to that stage already.
In line with this comment, I think that the GLOW study is a good study, even if probably results are expected, but not for the best population. So the population of the GLOW study is probably the population of patients that is too afraid to think about fully applying this combination, which is probably better for the younger patient population, which I would see better suited for this treatment. And I see probably an increasing use of this combination in the future as soon as new agents will come available, because if we use BTK and BCL2 inhibitor in the first line, then we are probably running the risk of missing some opportunities for the relapse patient, which is expected to happen. So in the future, with novel BTK inhibitors, non-covalent and novel agents, I think that this combination will represent a more important option for young patients than now.
Martin?
Yes, so I have a comment more from the sideline, let's say. I'm working on leukemic lymphoma, as you know, but when it comes to CLL, I'm very pragmatic. And, median age is about 75 years. With the appropriate cardiac comorbidity. So I really divide my patients in let's say, 3 different portions. The real elderly ones, I really start with the monotherapy, to be honest, to be as smooth as possible. And then we have the intermediate age patients where I move on to the doublet. So let's say 65 to 75, which are then mostly the patients where I consider venetoclax plus obinutuzumab. And that's based, of course, as Uli was referring to, the work of the German CLL study group. But there are still these younger patients who are rather fit. And in these patients, we discuss a lot about cardiac side effects, but we have just performed this large study in these patients in mantle cell lymphoma, and the younger patients, you don't see this toxicity at all. And for these patients, let's say age 59 or so, it's not a perspective to go on with treatment over and over again. So forever, essentially. So for them, this time-limited approach is really of benefit. And in these patients, this is one of my preferred options.
Francesc, your hand is up.
Yeah, thanks. I think regarding the benefit of this therapy compared to others, I think we don't have a clear answer. The figures appear similar to other therapies with similar progression-free survival with continuous therapy or other time-limited therapies. Probably next year, 2025, we will have the CLL 17 trial that is comparing I plus V versus Ibrutinib versus venetoclax or venetoclax. That is probably is going to answer or not whether one of these therapies is more beneficial or not. So until then, I think we don't have a recommendation in terms of efficacy of the treatment.
I agree that the results of the CLL 17 will be very important because we also have the fixed duration option of doing venetoclax plus obinutuzumab, and preserving ibrutinib for later relapse. So I think if we want to give fixed duration, we have these two choices. So how would you choose between venetoclax plus obinutuzumab versus ibrutinib plus venetoclax? So who would like to give their opinion? Have you all incorporated this in your clinical activities? I plus V, is it approved in all countries? Yes.
It's approved.
Is not.
Yeah.
Okay.
It's approved.
Astrid, okay. I don't have an answer to this question because, of course, we don't have data. But I think that the problem here that we need to get from the next trials is about sequencing, about the possibility to treat again a patient, to re-challenge a patient with the same combination, but with the same drug, and to see what happens to the outcomes of the patient. If we are impacting them, if the patient is still benefiting from taking the same agent for 2 times or for more times than just a single treatment. So I think this question cannot be answered now.
Yes, I agree, it cannot be answered. I still think that CLL is a chronic disease, so we have to think of this disease and of the treatment as a long run, not as a marathon, not a short run. So I have my doubts about whether V plus I is the best initial treatment. We have to see what happens when those patients relapse, and maybe, as you just mentioned, we can treat them well with either of the 2 therapies, or maybe we have new therapies by that time. But I think of the treatment for my patients as a long term. So it's not just the best now, and I still think that other fixed combinations are giving very good results.
Maybe just as a side comment, given the fact that this regimen is not approved in the US, I think we are all looking towards fixed duration therapies and combination of different agents. If we want to use approved agents here, we'll obviously use venetoclax plus an anti-CD20, which is the primary choice for patients who wants to have a time-limited therapy, with all the same concerns that Uli mentioned regarding the admission of this patient and the management if they have a high tumor burden of the TLS risk. But having said that, I think that these time-limited trials are building the landscape in CLL, and whether you use 2 or 3 drugs is probably one of the major questions that need to be answered. And if 2 only, is that a BTK plus a BTK inhibitor plus venetoclax, or is that an antibody plus venetoclax, and whether you can drop one or the other. So some trials will answer these questions. They will answer also the question of the different BTK inhibitor efficacy and tolerability in this setting. So yes, this is for sure the way to go. And even when not available, most of the trial we propose to our patients, if we have a trial with time-limited therapy, even actually with an antibody and a BTK inhibitor, where we have a trial guided by response to limit the duration of exposure to a BTK inhibitor.
Martin?
Well, I get out of the woods and make up some speculations. As been discussed, we all wait for the direct comparison of these 2 approaches, and based on what we have so far, I mean, it's fair to say that the doublet anti-CD20 plus BCL2 inhibitor has some slightly better tolerability. I do see the challenge of the tumor lysis syndrome, or managing concerning the ramp up, but still this is part of experience. The question is it as good as the IV doublet, which has potential advantages because the individual compounds are more effective. So therefore, we what we are all guessing is there a subset of patients which specifically benefit of the IV combination? And the jury is still out. So we are waiting for this analysis. We don't have it. My personal bias is that it's on long range, it's slightly more effective. It potentially has a slightly more side effects, and it's always the question of balance. And as referred already, for me in the younger patients, I haven't seen these really more serious cardiac toxicity, and therefore this is the first patient population I would pick. The question is, can we identify any molecular markers which specific, where the patients specifically benefit from this combination?
So one more question. If you use this combination, do you test for undetectable minimal residual disease at the end of therapy? And if you do you do it in bone marrow, in peripheral blood, and with what method?
No.
No, okay. Anyone giving a yes?
Yes, we do, but we don't draw any consequences from it because we told the patient that it's a time-limited treatment.
So, yes. Well, we analyze MRD, and it's negative. We say to the patient. If it's positive, we say nothing. So that's it.
Okay.
But we don't take any consequence yet about that.
And if you're already decided that you're going to use this method, this treatment, is it important to have the IGVH mutational status?
Yeah, I think this is very important. And this is one of the concerns of the MRD analysis, because we realize that mutated MRD are tending to take a long time to respond, and the MRD negativity is lower, but they relapse late. So at the end, MRD negativity, I think it has no value yet with these combinations, and that's why we are doing this up and down with MRD in CLL, because now we realize that MRD status maybe is not so important as was predicted.
But the mutational status may be part of the difference between IV and OV venetoclax. So that's going to be interesting, because that's one of the weak points of the OV venetoclax.
And we have a couple of minutes for patients who have lymphadenopathies at diagnosis. Do you evaluate with a PET-CT after end of treatment? No?
No. So the only exception is when I doubt or suspect some transformation, then a Richter's transformation, then I do apply PET, but not at the end of treatment.
Okay. Any concluding remarks for this new option of treatment? So I think we all agree that it's a good option, and we're waiting for the results of CLL17 to see which is the winner.
I think it's going to be a late-breaking abstract on Ibrutinib fixed duration, so we will have more data on that.
Okay, thank you. Thank you for your inputs on these questions. We can go on with...
Well, very well done, Astrid and colleagues. And even if this was more European and rest of the world than US, I think it's an interesting perspective on this topic, knowing that obviously Ibrutinib in the first-line setting has been completely displaced in the US by the other VTK inhibitor.